Welcome to the College Connection podcast, a podcast presented by the College of Registered Nurses of Newfoundland and Labrador. This is the College Connection podcast.
Welcome to the College Connection podcast. The College Connection podcast is made available to registered nurses and nurse practitioners as a resource to promote good practice and to highlight the importance of regulation in healthcare. My name is Kelly Kane, and I'm a registered nurse and a nursing consultant with policy and practice at the college.
And I'm Michelle Carpenter. I'm a registered nurse and a nursing consultant for policy and practice at the college as well.
We have a great show for you today as we discuss quality documentation is your best defense. And with us today, we have Brenda Carroll, who is a registered nurse and the Director for Professional Conduct Review at the college. Thanks, Brenda, for being with us today.
Thanks for having me.
Brenda, in our previous podcast episode related to the top 5 PCR cases, documentation was one of the concerns on the list. Can you provide some details with respect to challenges seen related to documentation?
Oh, for sure. It's quite broad, actually, when you think about it. We are seeing definitely an increase in challenges or complaints being brought forward with respect to register and practice regarding documentation not meeting expectations. In some instances, that can be challenges with grasping the EMR, where individuals are using electronic medical records. But even when we're seeing paper documentation and electronic or mix, it's really about either things not being documented at all or being documented poorly in that they're not complete. Sometimes it's that it's not timely. And I know you probably think when I say not timely, it's late, which, yes, that's part of the problem. But we're also seeing sometimes with medication administration, pre-pouring of medication, where people are signing the MAR before they've actually given the medication. So that timeliness, it could be too early, it could be too late, it could be not making that late entry in an appropriate way. And unfortunately, and probably even most concerning, is we're actually seeing a lot of false documentation. So either documenting things that haven't been done, and be careful with this one, because sometimes this is those checklists and people just routinely go down the checklist. Oh yeah, check, done. Checking a checklist is charting. And if you check something as done that it wasn't done, you've now false charted. But we are seeing more surreptitious false charting where people are actually sort of, putting in glucometer readings that they, never really actually did a glucometer check, or documenting things as being done or being done at times that are not actually accurate to when they occurred. We're seeing some of those kinds of more intentional false documentation as well.
Yeah, and when you mentioned that about, checklists, at a previous place where I worked, for anyone on a close observation, so every 15 minutes they would, a staff person would have to see the client. There's been instances where, either at the beginning of the shift or at the end of the shift where someone would just fill in all of the blanks, indicating that they have seen this person every 15 minutes. And that would indicate then that staff person never went to break at all and was on the unit the whole time. So, when you see things like that, I guess that just raises a few eyebrows.
Absolutely, and it's very much a dangerous practice to get into, because really, as you know, and as our documentation standards indicate, our documentation has to be contemporaneous with events. So you do something, and then you chart it. Right. And I think the other one sometimes we're seeing is, when I say lack of documentation, there's a couple of things like, a lot of times people will chart, the client's complaining of pain. Pain is, 8 out of 10. Pain is located here, reported to be stabbing pain, whatever. And they'll do a very good entry when they've assessed a client who's saying, I'm uncomfortable, I need some pain relief. But they're not looping back and sort of saying, 45 minutes later, I went back. The client's indicating there's relief. Pain is now 2 out of 10, etc. So I think it's also all those good practices partly because that documents what you've done and it documents the patient journey. But we also document not just from a liability protection piece, but we document to tell the story of the patient.
Absolutely.
Right? So that the next person taking care of this individual, or the other allied health professional, or the physician who's trying to put together plans of care for their domain, has accurate, fulsome information to base their opinion or their expertise on and make those decisions.
Okay. And going back to our principles, documentation includes all parts of the nursing process. So you want to make sure you have that response or the evaluation of the interventions.
Yeah, and Brenda, one of the things that come to mind as well, we hear, there are legislative requirements. There's best practice according to ISMP when it comes to, double checking and double checking high alert meds or insulin. Are you seeing any issues with those type of requirements?
There are a couple. The double checks are critical. I think sometimes, again, everybody's busy and you think, I'm just going to do this and I'll get somebody to come sign it off later. And the point isn't just to get the initials on the page. The point is you're dealing with a high alert medication. It's not just the initial on the page we're looking at, but what you're saying by putting your initials there is, I saw you drop that medication. I know you dropped the right medication for the right patient, the right dose, the right time, the right route, those rights of medication administration. You're saying, I double check those with you. And from a patient safety perspective, we want to make sure that I have done my diligence. I'm not just signing that I know you did it. I'm saying I did it. And so making sure those double checks are filled out is critical. And the other reason that is, and this is more that the first piece being the patient safety piece, the second piece being the liability piece. If you're not having someone double check your medications, you're open to scrutiny. And if there's, a miscount or a misalignment in the count, people who don't get wastage or don't get, controlled substances double checked when they draw them up or would take them out of the NARC cupboard or whatever, those are red flags that we look at in your practice. And if your medication administration practice, most importantly, your documentation around medication administration isn't meeting standards, it can leave people open to question whether your medication administration is appropriate. So it is critical, and I think we are seeing more and more of that. The other one is do not use abbreviations. Those when you're using EMR and MARS and we're using pharmacies have really gone a long way to reduce those. And a lot of the EMRs won't even let you put those in. So there are some controls on those do not use abbreviations, but it's still important to know what those ISMP do not use abbreviations are. It's an accreditation standard. There's employer policy at every acute care facility and every long-term care around those. And you need to be able to recognize them, mostly because you're not supposed to use them, and you're not supposed to use them because they create patient safety risk.
Absolutely. And Kelly mentioned, documentation is not optional. It is a part of nursing care. So, it's very concerning when you hear, registrants saying, I'm too busy to document. So here lies the reason why we're asking you to speak to, in this podcast, right? Brenda, CNPS has been quoted in the past stating that quality documentation is your best defense. What does this mean, and why is it important?
And this speaks to that professional liability piece. We all heard it in nursing school, and it's still true to today. If it's not documented, it's not done. And that's the very most basic premise. And again, you're documenting what you've done to ensure that you've met the expectations of your role as a registered nurse. And so if you don't write it down on paper, the assumption is that it wasn't done. And you may think that, I'll remember, I would never forget having this done this procedure or provided this medication. But, most nurses are hard-pressed to remember what they did the day before, let alone if you're involved in some kind of an inquiry or a morbidity, mortality review, or a lawsuit of any kind. Those things sometimes can take up to years to come to fruition, and your memory will not serve you, and your memory will not have the same credibility as what you put down on paper at the time. And so it is really critically important that you document fulsomely and timely and make sure that it's accurate.
Absolutely. And Brenda, we work within collaborative teams, so I guess, there's an importance to document the care that you provide so that, the appropriate healthcare providers within your team can follow up on that, can see the care that the client has received, but also to know what is that assessment and what was the outcomes of your care. So you want to speak to that?
Yeah, and I think that's the quality patient care side of the reason why we document, right? Is we know we're striving to give the patient the best care possible. It is a collaborative team effort when we provide care to patients entrusted in our care. And it's a communication tool.
Absolutely.
So you're facilitating seamless transitions in care when you document appropriately. And that includes documenting on the patient chart. It includes documenting your written handover report if there's such a tool being used in your organization. All of those things are encompassed in your documentation, and they're all official documentation. So we have had instances where individuals have thought, well, the chart is the only official nursing documentation. These other pieces of paper that we use are kind of, not really official. So I'll use my do not use abbreviation, or maybe I'll use some unprofessional language, or maybe I'll, draw a little illustration to lighten the mood. Be careful about those things, because everything you put pen to paper on could be considered part of the patient record. And so it has to be professional, it has to be accurate, it has to be fulsome. And those are tools to facilitate that communication in transitions. And it's also tools, as I said before, for other members of the healthcare team to glean information about the patient journey. And you're really telling the patient's story when you document, and you're speaking to their journey, and you're documenting what you've done, what you've assessed. And that includes, I know we talk about exception charting, but sometimes it's important to make sure you indicate what you didn't see if it was expected as much as it is to report what you did see. So it's about being thorough and complete.
Great. Thank you.
Absolutely. Brenda, our standards of practice, so Standard 2, knowledge-based practice, talks about documentation. And our standards say that registered nurses and nurse practitioners must have timely and accurate documentation. So from a regulatory perspective, what is the value of having that timely and accurate documentation?
Yeah, I think timely is one of the ones we see some of the biggest challenges with. And I think, and most often sometimes, it's people who leave their charting to the end of a shift, right? And that's a really bad practice to get into, because what if that patient takes a southward turn and all of a sudden has to be transferred to a higher level of care in the middle of your shift, and you've got none of your charting done? How are you facilitating that communication to that next care provider? I know we always think, oh, they're mine for the shift. I know what's happened. It's all here on my cheat sheet. I'm just going to sit down, do all my charting at the end of the day, and then it'll be done. But there are times you may go on break, and what if someone takes a sudden turn for the worst, or an allied healthcare provider shows up, the physician shows up, has a question, and no one's able to answer a question. These are all things that interrupt the quality of care for the patient and create risk. So it's really important that you're doing periodic charting through the day, not leaving it to one entry at the end. Certainly, as we've talked about, don't pre-chart. That's really bad practice. And I think the other thing is about being accurate is, if someone questions the accuracy of your charting, it not only calls into question that patient care episode, but every other patient care episode that comes from you, right? So think about this as your professional reputation. And once, sometimes, like if you're in an inquiry, you may get asked, did you chart this? It is always I cannot speak to specifically from memory what I did on that day, but I can tell you it is always my practice that I check the MAR, I take my medications out, I go to the patient room, I use my 2 client identifiers, I witness the medication administration, I go back to the MAR, and I sign for the medication. And sometimes that's the best you can say. But if you're going to rely on that and say, this is what I do all the time, this is my practice, but you've filled out a MAR before you administered a med even once, you can't say that anymore. And so it really puts you in a precarious position in that your reputation for accurate, timely documentation is now in question.
Absolutely. And you mentioned a couple of the poor practices with respect to saving it to the end of the shift or documenting beforehand. And best practice is point of care documentation, right? From the regulatory perspective, we expect, as contemporaneous as possible, so as close to the time of care as possible. We recognizing sometimes emergencies come up and things happen, but a general rule would be as close to the time as care as possible is what the expectation is.
That's right. And if it's quite delayed, then making sure that if you're doing a late entry, that it's done appropriately in accordance with policy, so that it's clearly identifiable as a late entry, and following the employer expectation around those late entries.
And again, best practice, what the regulator expects is that, as the client's predictability and stability, and as their plan of care is changing because they're becoming more critical or their status is changing, then you would expect more documentation and more timely documentation, because as you said, that client could become very ill very quickly, and we need to be able to communicate what interventions that we've done for that client in that short period of time. So those coming after us or coming to assess that client knows exactly what's happened.
Exactly. And that's why when you have a code or a situation where a client is deteriorating rapidly in an ICU, so there's 100% why there is a nurse assigned to be the nurse that does the documentation as their things are happening.
Absolutely. And I guess the best, now that you spoke about that, again, best practice is that there is a person designated, and that's one of those exceptions where we say, rather than the person who's providing the care, in our documentation principles, we say that there are certain exceptions. But it's also important to go back and review that documentation that designated practitioner provided to ensure that it is accurate, and you may have to document something if it's incorrect.
Absolutely, and there are processes again to allow you to do that, but you're absolutely right. Documentation should be done by the person who carried out the action or carried out the assessment, who did the activity that's being documented. Never document for others, and that goes EMRs. Please make sure you log off. Please don't share your login credentials with others, right? Because we have had instances where people have charted under someone else's login accidentally. And this, again, opens up for risk and patient safety issues.
Right, absolutely. Okay, so what should a registrant do if they feel they aren't able to meet the expectations or think others aren't meeting expectations with respect to documentation?
Right, and I think if it's yourself, I think what that speaks to is your professional responsibility to be aware of what the expected standards are. What do the documentation principles say? What is your employer policy with respect to charting and documentation? And if you feel that you aren't able to meet those expectations, you need to raise your hand. So if you're struggling to learn an EMR, or if your workload is such that you feel like you just can't get to the the charting piece of your responsibilities, you need to put up a hand and say, I need some help. And so that's the first piece, is knowing your own abilities and knowing the expectations and whether you're meeting it, and being able to do that self-assessment and then ask for assistance. If you see that others aren't meeting expectations, so maybe you come on shift and you're trying to figure out what happened on the shift before you and there's just not a lot of information there, then you definitely have the obligation to sort of, again, raise a hand, go speak to that individual and say, hey, listen, like, this is what I came on to, this is what I saw in the patient record, and it really was very difficult for me to do what I needed to do because there was so many gaps in the information here, or this was missed or that was missed. Have those conversations with your colleagues. You know, sometimes that's all you need. If it's just a matter of they're meeting the expectation, but they're just barely getting by, you're just going to boost them up a bit. If you see really concerning practice, if you're concerned that, you know, people aren't documenting, or they're documenting medication they didn't give, or they're, you know, documenting someone's blood sugar when you know that they haven't checked it. If you're seeing those kind of glaring errors, you do need to have that conversation with them, but you do also need to escalate that. And you have an internal process as to how you would deal with that with a manager and sort of from an HR lens. But if you have direct observable evidence that's objective, then you also may have triggered your duty to report to the College of Registered Nurses as well.
Yes, and you know, Kelly and I are here, we're nursing consultants. If they have questions related to documentation, how to meet documentation expectations, they can call us for support as well. So, Brenda, is there any other tips that you can suggest to ensure that RNs and NPs meet their documentation expectations?
I think in general, it's just, like I said, I think maybe one of the biggest surprises that we hear from registrants who come across my desk related specifically to documentation is that there's more to documentation than just the individual patient chart, and being mindful that all of your communication has to meet the documentation principles, be aware of what those are, and make sure you're following the guidelines and expectations. And if you're not able to, you know, sort of reach out and ask for help. And because communication is probably one of the most easily fixed challenges when it comes to patient safety issues. Like when you do patient safety reviews, almost every single one of them will come down to there was a communication issue.
Right.
And if your documentation is appropriate, you have reduced and mitigated that risk dramatically. So be aware. Make sure you're meeting expectation, and if you're having challenges, make sure you ask for help.
Absolutely. And Kelly and I often say in education sessions that if you adhere to your standards and your code of ethics and you work within your scope and you have quality documentation, should the occasion happen that you are called into a court of law or into a review, then, you know, that will be your best defense, right? It's not to say that an allegation couldn't be laid or a case couldn't be held in court, but having that documentation to support your practice will be your best defense.
Yeah, absolutely. I mean, the CAC reviews a lot of documentation, so that's our Complaints Authorization Committee. And when complaints come in where a registrant contests the complaint, the CAC is the one who takes a look at that. And oftentimes, whether they dismiss something or move it forward, it's either because they had documentation to support one sort of fact pattern, or it's because they didn't have any documentation. And then maybe it'll go to investigation and we'll gather that up. But, you know, it can make your life a lot easier if the documentation is there and complete and accurate.
That's good advice.
Okay, that concludes our episode with the Director of Professional Conduct Review, Brenda Carroll. Thank you, Brenda. And thank you to our audience for tuning in to today's episode. Remember, all episodes of our podcast can be put towards our continuing competency requirements. And also remember to subscribe to our channel. And we encourage you to like, review, or leave a comment whenever you can. Thanks.
Thank you.
Thank you, Brenda.
This has been a presentation of the College of Registered Nurses of Newfoundland and Labrador.